Hello, welcome back to PCM4U channel. I'm here today with Katriina. So Katriina, could you introduce a little bit yourself, your activities to our public?
Okay,
Please.
perfect. Great to meet you all. My name is Katriina Jalkanen. I'm a medical oncologist and I live in Helsinki. I work at the clinical trial unit at the Helsinki University Hospital. Actually, I'm a chief physician there, and then I'm the coordinating PI for the FINPROVE study, which is the Drup Trial study running in our country currently.
So could you tell us a little bit about the molecular testing for patients with cancer in Finland and how it's organized?
Okay. So I have to admit that we're sort of more or less in the process of amending and getting to a wider uptake. The main problem is that it's not governmentally funded, so it's not reimbursed, not even like a larger panel, for, let's say for 500 oncogenes. Only the reimbursed are like local NGS panels that contain around 50 to 70 genes, and not necessarily fusions. So it's more or less up to the treating physician what he or she chooses. And then we should purely lack at the current moment like national guidance for which patient and which stage of the disease. So unlike in Denmark where they screen, all patients at a metastatic site, we lack that, and that's something that we're aiming at and have already ongoing discussions with also our authorities to pick up, since there are a lot of standard therapies that need also molecular profiling for example, FGFR fusions and TRAC fusions, even MSI. So we do that for, let's say, GI cancers. That's a standard of practice, and lung cancer evidently. But until now, the countrywide NGS panels for lung cancer, they're still quite sort of short, so you may lack. There's up and coming new molecular alterations. And then, of course, trials that we could try to get patients within if we know more widely what type of other fusions, insertion mutations, and so forth they have.
So coverage of molecular testing is more for lung cancer patients?
The lung cancer and GI cancers at the current moment. And then some of the gynecological cancers have been, since there are a lot more translational interest in that, and that's due to a couple of physicians that have been really sort of enthusiastic. But the problem is we have 5 university hospitals and they govern the whole sort of country in tertiary care. And those panels sort of need to be distributed to the local regional hospitals so we can cover and have equal treatment and equal opportunities for also molecular profiling within the country. So that has been really hard. And at the current moment for FINPROVE, we use the university hospitals. So they have like satellite spots in the regional hospitals. But that's in the making as we are speaking right now. So there's quite a lot still to do. As you may know, Finland is quite a large country. Although the population is only 5.5 million, but we're nearly the size of California. It's 80% of California, so it's not small. So the distances are very long.
So you mentioned FINPROVE. This is a trial to allocate patients with targeted agents based on their molecular profile.
Yeah, correct.
Could you tell us a little bit where you are in this trial right now and what are the perspectives?
Okay, perfect. Thanks. We've been up and running recruiting since January 2022, so a year and a half now. We are truly national, so all of the 5 university hospitals are participating, but the difficulty now is the uptake of molecular profiling. We have 15 drugs in the study at the current moment, and a national MTB that governs at a weekly basis. So all patients that are referred to our hospital go through the MTB, and then evidently they may be also recommended to another trial perhaps, or then if we lack anything else, then FINPROVE. There's also some open access and named patient programs running in the country, luckily, but that's been more difficult in the current years than it used to be. Like I understood in France, all of your new up-and-coming drugs go through an open access program, so that's not something that we lack.
So how much patients have you enrolled for now in this trial?
It's nearly 100 patients that have been offered treatment within FINPROVE, but there's been a very sort of learning lesson that we've profiled the patients too late. So in the beginning, it was nearly 60% of the patients that unfortunately progressed or deteriorated prior to the capability of entering the study. But now I think the lessons been learned. They've been profiled a lot sooner. So it's nearly about 40% of the patients are still waiting on previous lines of treatment. So they've been at that early stage, and then of course we need to take a new either biopsy or liquid biopsy upon treatment initiation within FINPROVE.
Yeah, I think that's a good take to anticipate the molecular screening in order to have time to have the results and think about the next treatment line for at least for metastatic.
Yeah, because it used to take around 6 to 8 weeks. Now the turnaround time is around 2 to 3 weeks. We've got improved in that. But evidently, if you're already exhausted for standard therapy, it's too late at the stage to start profiling at that moment. And of course, I've been like an advocate in the country trying to speak about the fact that we need to profile these patients a lot sooner, since there are a lot of standard therapies even earlier line trials that would be perhaps more beneficial than for example, let's say pancreatic cancer, some upper GI cancers that lack that efficacious treatment.
And of course, you have complementary clinical trials dedicated maybe to patients with specific cancer and biomarkers that could increase the number of opportunities to be included.
Definitely so.
So thanks a lot for all your thoughts about these different subjects. I'm sure it's very valuable for our public here. And see you soon, Katriina. Thanks again.
Thank you, Glenn and Loic. This was a pleasure.
Nice.
And hope to see you soon on the channel as well.